called G3P3. She had a long history of menorrhagia, so she had a lot of bleeding problems. She was treated in 2011 with an IUD, but that didn't work for her as well as she wanted. So she had an endometrial ablation that did work for about 3 months, but then her bleeding came back. Before they started the case, they had an H&H of 10 and 30. She was obese. She had a BMI of 34. She had had 3 previous C-sections. Of course, she was a G3P3, as we had mentioned. She was on iron, and she was a non-smoker. Physical exam. She was 185 pounds and 61 inches, so 5'1". Blood pressure was fine, heart rate fine. Her CBC, right before they did the procedure, they did a hysterectomy, and her CBC showed the hemoglobin 11.3. There were 3 large fibroids that they were expecting based on the ultrasound. They were, I assume that's centimeters?
I figured, yeah.
7 centimeters, 4 and 4 centimeters. Those are pretty big for a little uterus. So in the operating room, she had 2 large uterine segment fibroids, and they happened to be at the level of the uterine arteries. So both uterine arteries on both sides, there was a big fibroid there. So they attempted to remove the fibroids first, and there was a lot of bleeding. And Dr. Wagner was involved in that case as well. So after they had removed those, the blood loss was 1,500 mLs already. They did take the uterus out, and they tried to clamp off the arteries, but they had difficulty there and continued bleeding. Then the patient's blood pressure dropped. She had tachycardia, so her heart rate went up. And she ended up getting a transfusion during the procedure, but they were still operating. She got 3 units of packed red blood cells, and then her blood pressure and heart rate stabilized. And they finished the hysterectomy, and she did okay. Her H&H after the entire procedure, after the transfusion of 3 units, showed a hemoglobin 8.7, hematocrit 26.7. Significantly lower than where she started, and probably much higher than wherever she was before the 3 units of blood.
Okay, so anemia obviously is not a single disease. Many causes of anemia can be there are many underlying causes of anemia. So we're going to limit this talk to acute bleeding, because that's what this case was. So the word anemia comes from Greek meaning without blood, and it's strictly defined as a decrease in RBC mass. But because measuring RBC mass, it's time consuming and it's expensive, so we use hemoglobin and hematocrit as surrogate measures. And anemia results in a decreased ability of the blood to transfer oxygen to the tissues, resulting in hypoxia. So anemia can be classified in a couple of different ways. Either by pathophysiology, which I think is maybe useful clinically, or you can define it or classify it by morphology, which is what we use as pathologists when I look at the peripheral smear. So by pathophysiology, it can be increased RBC loss, which would be bleeding, like in this case, decreased RBC production in the bone marrow, either because there's not enough iron or folic acid or B12, or there's marrow suppression, or the patient has a viral illness or some underlying disorder, and increased RBC destruction, which is what you would expect in hemolysis. The morphology is what I use, and basically that is determined by the MCV, the mean corpuscular volume, which is the average size of the RBC, and that can divide the anemia into microcytic, normocytic, and macrocytic. I'm going to skip over much of the right side of this slide, but basically the RBC count, the hemoglobin, and the hematocrit tell whether we have an anemia present, and the MCV, MCH, MCHC and RDW tell you, or at least help determine the cause of the anemia. The RDW is a measurement of the variation of the size of the lymphocytes. So red blood cells. So if you have red blood cells that are of various sizes, the RDW is going to be increased. And it is increased with the normal MCV, so that's how I use it. I look at the MCV and I look at the RDW, you can put it together, and if in this instance, for example, if you have an increased RDW and normal MCV, that's associated with early iron deficiency or vitamin deficiency or folate deficiency. And I'm putting that example on purpose because here are the labs. So the left-hand column are her labs before the surgery. Sorry, I can't get an arrow, can I? Shoot. Okay. So on 3/20, March 20th, her hemoglobin and hematocrit, she's mildly anemic, little less than normal. If you look at her MCV, it's 81.9, so that's normocytic anemia. And if you look at her MCH and MCHC, which is the mean hemoglobin concentration, or just mean corpuscular hemoglobin, those are slightly decreased and the RDW is slightly elevated. So that tells you that it's a normocytic anemia. Now look at the right side. With a slightly increased RDW, so the previous slide where I was telling you, so that means that she is slightly iron deficient, and that goes along with her history because she had been bleeding for a long time, and she was on iron therapy, so the anemia was just mild, okay? So then after surgery, even after 3 units of blood, her hemoglobin has only gone to 8.7, so that was a significant blood loss. But because of all the normal red cells that were put in, her MCH and MCHC are okay. All right?
It's 1 gram per unit, is that correct?
1 gram per unit.
So if you took it 1 gram per unit, she would have been down in the 5 level without the blood.
That's right. So, we have an acute anemia. That's usually due to hemorrhage or hemolysis, and hemorrhage by far is the most common cause. And hemorrhage can be GI hemorrhage, we see that all the time. GU hemorrhage, which is in this case a surgical, which also in this case, you can have trauma, ruptured aneurysm, ruptured ectopic cyst, any of these acute situations. And when the anemia is acute, the body doesn't have time to adjust. So the symptoms are more dramatic and they need attention faster than if the anemia were chronic. So it's generally accepted that an acute drop in hemoglobin of 7 to 8 will cause some symptoms, whereas you can go to levels of 4 to 5 if you have a chronic anemia. In fact, it was very interesting that just happened today. I walked in and we had 2 cases of anemia. One lady had a hemoglobin of 2.8. You wouldn't even think that somebody could be alive with a hemoglobin of 2.8. And 2.5 is the lowest one I've seen. But obviously this was a chronic situation and somehow she adjusted and she is alive and doing okay as far as I know. And then the other one was 3.1. So it goes to show you that in people who have anemia for a long time, the body has ways of adjusting. But in this acute severe anemia that we're talking about, we worry about tissue hypoxia and shock, hypotension, coronary or pulmonary insufficiency can occur. And of course we have tachycardia, tachypnea, which this patient had. She was symptomatic. So now we're going to talk about indications for transfusions. And of course you hear me talk about, being very judicious about giving blood. And this is something that is going across the country. Everybody is talking about it. This first quote is something I hadn't heard, but I thought it was a little funny, by the director of the Australian Red Cross. Blood transfusion is a lot like marriage. It should not be entered upon lightly, unadvisedly, or wantonly, more often than is absolutely necessary. And then the second quote actually is something I hear all the time. I don't know where it comes from, but they say it in any pathology meeting I go to where I go to a blood bank lecture, is red cell transfusion should no longer be regarded as may help, will not hurt, but rather should be approached as first do no harm. So obviously a blood transfusion can be life-saving and provide great clinical benefit, but it is really a foreign substance. And so it is like a small liquid transplant every time, and the body knows that something foreign has gone into it. And that, they call it transfusion-related immunomodulation, where the body is perceiving it as a foreign substance. Studies have shown that increased post-operative infection rates, ventilator-acquired pneumonia, central line sepsis, ICU, and overall length of stay, mortality, they are increased with transfusions, except in people who've had MIs. That doesn't apply. They need the transfusion. And also there's been talk about RBCs that are sitting in a bag are losing ATP, and so losing some effectiveness, and maybe an increase in lipids, which we'll come to later, which may cause some harm. I'll talk about that in a minute. Also, the U.S. has higher transfusion rates than many countries, 15% higher per capita than Europe, and 44% more than Canada. And decreasing transfusion may not only decrease costs, but improve outcome. This form, I just put this up there for just a second. This is the transfusion form that they use at the 86th Street. And I only copied the one for the red cell part, not the platelets and the fresh frozen and stuff. I'm not going to talk about that. It's a 3-hour lecture. But Dr. Timothy Hannon is an anesthesiologist at 86th Street. And he got interested, I guess, in transfusions, and he has transformed the hospital, and he's become a nationally known speaker. I follow him around every lecture he gives, and I told him I was his groupie because, just kind of to learn, like, how is he doing it? Now, I'd also like to say that in this hospital we are doing really, really well. The doctors are just following directions. We're always, I think sometimes 75%, the indications we're following, where hemoglobin should be less than or equal to 7. And if we give blood for a higher hemoglobin, we document the indications, and then I look at them at the end of the month, and we go over it in our department meetings. So this talk doesn't mean to imply about the physicians here, but this is a talk that everybody is having across the country. In this case, I highlighted in red that we met criteria. If you notice, she lost at least 1,500 mils, probably more after that unclamping of the artery.
So I just want to point out that if your hemoglobin